We're going to start with a scenario based on the current Ebola virus outbreak. But I'll just make one observation, really, which is that since March, when WHO announced the beginning of this current outbreak, it's really brought together the international community in an unprecedented way, not just in the countries that are affected and in the region that is affected and in countries that have had spread of the disease, but also every other country, even without a case, because every country has had to make extensive preparedness efforts. And it's also brought together the health sector, because I think every healthcare worker, whether you're in Perth or whether you're working on the ground in West Africa, has had to think about what would happen if I saw someone, how would I react? And the human cost of this epidemic on the individuals, their families, their communities, and also on their healthcare workers who have to care for them, has really come through to us in what we read in the papers every day. It's very much felt, and I've been working with Chris on this for the last few months, like pandemic influenza in 2009 without a case here in Australia. But I know for many of you in the audience, particularly in the mining and resources sector, you have employees who are working in the affected countries, so it's been very much a present concern for you all. So, given our experience with the Ebola virus outbreak in West Africa this year, including its human and economic impact, both regionally and internationally, and let's assume and hope that it's controlled over the next 6 months. The scenario is, if it recurred again in 2 years' time, and remember, this is the 30th odd Ebola virus outbreak in the last 30 years, so it's likely to recur at some point. I'm going to ask the panellists, what would you like the international community to have put in place in a couple of years' time that would allow the response to be quicker and more effective? And I'll go to David first.
Thank you. Well, internationally, there's a convention or a treaty called the International Health Regulations. And this is a treaty that 194 member countries of WHO have agreed to, and it's a treaty which, among other things, requires countries to develop 8 core capacities in public health. This treaty was developed in 1969 when it was thought that you could keep infectious diseases out of countries at borders. Have any of you ever heard of the IHR, or have you carried a yellow vaccination certificate? If you have, you've participated in the IHR and probably didn't know you did. Because if, for example, Senegal would report to World Health Organization an outbreak of yellow fever, then any country in the world under the international health regulations could require that you have a vaccination for yellow fever and proof with a yellow certificate before you can enter their country. So there were a set of regulations which worked to try to stop infectious diseases at borders. By 2003, when SARS came along, it was understood that borders don't stop infectious diseases. It was clearly understood. And so after SARS, there was a revision of that treaty, those regulations, which at that time changed the emphasis from ports of entry to developing core capacities in countries. 8 core capacities required. 194 member countries of WHO agreed to that. There was a mechanism whereas each year they report to WHO, and the completion of those 8 core capacity strengthening activities was to be done by the end of this year, 2014. Well, to go backwards a bit, the donor agencies, USAID, USAID, DFID, JICA, various agencies did not build capacity within the IHR. That wasn't in their priorities. They were more working on other activities bilaterally rather than on building within the IHR. And countries were reporting what they wanted to because it was a self-assessment tool. And as a result, we see what happened in West Africa. There were not 8 core capacities in these countries that could have at least provided a base to which they could work with international partners to stop the outbreak much easier. So that's just a beginning of a dialogue, and maybe others would take over from there.
Thanks, David. Welcome to Chris.
Yeah, thank you, and good morning to you all. And to pick up from there, Australia is obviously one of the key signatories, one of the into the international health regulations. Involves us having a national focal point, which is in Canberra, and in fact within the Office of Health Protection, which is part of the Department of Health there, which reports through me. And we've taken our obligations and requirements completely and fully and reported fully compliant several years ago. The question then is, what might we learn from this experience for something in the future? And what I've taken from this, as I understood, this was the first time there'd been an Ebola outbreak in West Africa. And whereas we know in other parts of Africa, in Uganda, the Democratic Republic of Congo, they've had outbreaks in the past. And I noticed that one of the first countries to provide health workers to West Africa was Uganda. And I thought how appropriate was that, given their experience. And the other part that we've kept an eye on, you and I have kept an eye on, has been the outbreak of not of the same strain, but a separate outbreak, but at the same time in the Democratic Republic of Congo. And this mightn't have received the same publicity, but I was just very impressed by what happened there. We had, in the end, 66 cases of Ebola. I think there was something around 40 deaths, Tarun. And but then it stopped. And, a country gets declared Ebola-free once it's had 2 incubation periods from the last negative test of the last known patient. So that's 42 days. And so the Democratic Republic of Congo, through its public health measures, and obviously through understanding the issues and cultural aspects, and David, you and I have spoken about that, was able to manage and contain and then stop an outbreak. Now, they've done that before, and so they've had experience with that. So, and part of it then is the local capacity. The health systems have been mentioned already. It was said by WHO that the health systems in the Guinea, Sierra Leone and Liberia were fragile, even at the start of this outbreak, and they've just been put under more stress there. So it's that the importance will be of building up health systems again in those countries, understanding that it could happen again, and having those public health measures, I think, is going to be important. Internationally, well, let's hope we do get, as a result of this, a vaccine that can make a difference, that maybe we'll get antivirals or other therapies, but I think the rapid public health response is going to be the key to this.
Thanks, Chris. Liz.
I think every outbreak has its own nuances, and the very valuable lessons we've learned from each one. I think with an outbreak like SARS, where we didn't actually know the virus or how it was transmitted, there were many valuable lessons learned of how we would respond just blanketly to that type of event. With Ebola, I think there were some very unique socio-political issues that happened with the outbreak in West Africa that drove how it spread. And with Ebola, we were dealing with a virus with known characteristics. We know how it spread. We know it's actually not that easy to spread. So I really feel that the response, and with each outbreak of any infectious disease, we've become much more sophisticated, that a robust laboratory response was really, and in the future, will be the way to control this. So if the disease can be rapidly diagnosed, if infection control measures can be actually put in place immediately, and if appropriate segregated hospitals and healthcare facilities can be put in place to minimize the impact on trade and commerce and economics in the society, I really think that's going to be what's happening in the future. And things have been moving quite rapidly in that domain in terms of research towards point of care testing, towards rapidly being able to rule out or rule in cases.
Thanks, Liz. My job is as a provocateur, so I'm going to just push you just one level deeper to answer this question. So if you were, a casual reader of the newspaper, you would have seen, some criticism already or some reflection on the role of WHO. And it seems, certainly to me, that WHO seems to be structured much in the way and have the same, problems as the UN, in that it tends to rely on member states. So that it doesn't have a lot of capacity already there, just ready to go at the push of a button. But the whole premise is, if the member states think that there's emergency, they'll put in at the time that it's needed. And you'd think as well that the health sector, we're good at health stuff, but the economic side would be easily recognised by, you know, the whole of government, including the kind of at the country level, as opposed to just the health bits of the countries. So there is a kind of a rationale for the way it's set up at the moment, which is if member states wish to respond quickly and if they see the economic and other impacts, then they'll be able to mobilise resources. So I'm kind of pushing all of the panellists this morning, what could we actually do between now and 2 years' time to actually address what we've known we should be doing in terms of capacity and other issues up until this point? David, I'm going to go to you first again.
Yeah, okay, well, I think that one of the things to do is to look and see how we can strengthen the core capacities in public health, but there are other lessons that are learned from West Africa, and one of those is with the mining industry and other private sector. They've been working in these countries for many years, but there's never been a resilience platform developed between the companies and the national government or the regional governments. And so what appears to have happened this time is that mining companies, for example, have had to shut down because the expatriates have left and the logistics support to those companies has closed down, whereas there's really no need for that to have happened. People can continue to work in an Ebola outbreak. There's no great risk of being infected unless you touch a patient, as all of you know. And so these could have continued and contributed resilience to the country, and a logistics platform which could have been in place and possibly could have avoided having to have the UN send in its logistics platform, and a whole series of things where public-private sectors could have worked better together, and which hopefully in the future will happen. So that's one observation about how things might proceed in the future.
Good. Do you do the same order, Chris?
Yeah, sure. I must declare that I've been on the emergency committee for the WHO, looking at the Ebola outbreak, and as you know, I chair the emergency committee for MERS. So, and I know many of the people at senior levels in WHO directly, as does David as well. And I think you've highlighted a number of areas that will be reviewed, and there will be a review of this. But I think the point that you make is that often, as I understand it, the way WHO is structured is that if there is something extraordinary that occurs, then an extraordinary response from the members is required. WHO doesn't have an army, a team of people to put into the field. It depends on the response from all the countries in the world and those who choose to respond. As you know, we've got a couple of Australians who have been intimately involved with this from the very start, Rick Brennan and Ian Norton, we both know well, who have been directly involved and reporting to the member states the circumstances as well as preparing for a response. So what I have seen is good people responding as the circumstances have escalated. There will be a review, and I think the review, though, needs not just to focus on the WHO, but on all the countries of the world as how we could respond and how we could respond better in the future.
Just before we go to Liz, are you optimistic that we can create a kind of new international public health system out of this? Can this be a watershed in how we think about international public health, Chris?
Well, I think it needs to be, and you know, we've got the GORN, that Global Outbreak and Response Network that is linked with WHO. I think there's so many lessons to learn for us all for the future that if this opportunity isn't taken, it'll be a hugely wasted opportunity.
I might just ask Liz was working in Toronto at the time of SARS. Just to reflect, that was 2004, just to reflect on her experience about what happened afterwards, what lessons were learnt in Canada.
Yeah, I mean, I think there was a lot to be learned during that period. I mean, just to reflect on it was really a 4 or 5 month period where healthcare services were largely shut down. And this was obviously in an urban environment that served a population of over 3 million. So you can imagine the necessary state that occurred when a virus whose transmission at the time was instilled. There's still some nebulousness of how SARS is actually transmitted in the reservoirs for SARS. But at that time, there were a lot of unknown issues of how to respond. And I think the actual stringent response of basically segregating patients, having patients on home quarantine and actually restricting outpatient services in hospitals was the right thing to do. But nonetheless, you can imagine the impact that had on patients with chronic diseases that needed attention and treatment, such as cancer and HIV. And I was involved from the standpoint of HIV, so I can reflect on the necessity of having to find other ways to see those patients and provide care to those patients. So I think in terms of what we've learned from that, I mean, from a number of angles, and this also applies to the Ebola situation, I think the number one thing is whenever you've got a response is to have something in place so it doesn't shut down the activity of the entire healthcare system. And that's also true and has obviously impacting the community at whole, because one thing that was very clear during SARS is there was a lot of fear. There was fear with healthcare workers. There was fear from nurses. There was, nurses that had co-workers that had died. I mean, it was a very, very fearful time. And having a response in place to actually feel that people have some degree of normality, you can imagine the social and economic consequences of such an outbreak as far-reaching when people actually just tend to contract under that kind of situation. If you can think of the outbreak as starting in March of 2003, and then in May of 2003, actually, the outbreak was actually declared over in Toronto, similar to the definition that Chris mentioned for Ebola in terms of 2 incubation periods away and no further cases. But then there was a second mini outbreak that totally impacted hugely on the population again, and there was actually a nurse death during that second outbreak. So I think if you can imagine just a 4-month period where you're basically almost quarantined, it was like being on work quarantine basically for 4 months, where you basically went to work, you went home, you treated patients at a hospital. Every day when you went to work, you were actually screened before you went into the hospital. For the first month that we were at the hospital, we didn't know how it was transmitted, and we were actually wearing masks 100% of the time in our offices, even when we weren't actually engaged in patient care. So it's a fairly huge social impact, and I think we can just reflect on it wasn't so much the response. The response needs to always be first line, safety first, security first, but maybe a number of other things around that could be in place to actually impact less on the overall social, economic state of the centre involved. So I think there's been a number of things in place that have been.
Thanks. No, thanks, Liz. That's a really great description from first hand of what happened and the impact on an entire healthcare system. And we've certainly been worried in the last few months that all of our attention on, Ebola and detecting cases could detract from the same traveller returning with something much more common, such as malaria, and being treated quickly and effectively for that. So we must be careful of that. But also you mentioned about fear, both in healthcare staff and in the wider community, and the impact that can have. So we'll come back to some of the economic impacts just a bit later, and I'm sure the audience will also have questions about that. But I might just shift into the health business more centrally. And just an old thorny one, I suppose, which is, it's fine to talk about these big picture issues about learnings, etc. But there's some basic stuff that we've never been able to get right in healthcare. And the oldest one of all is, doctors washing their hands. You'd think 150 years after knowing about the importance of this, that we'd have 100%, hand washing rates. And if you walked into a hospital today, I think you'd probably expect that, all of your healthcare professionals would wash their hands before seeing you. Unfortunately, that's not the case. So if we can't do that kind of simple stuff right with our healthcare professional groups, what chance have we got on these bigger picture issues? Now, that's a provocative question. I'm going to ask the ex-CEO of the Safety and Quality Commission in Australia, Chris Baggoley, to start.
Oh, that was me. Oh, there you go. Look, it is one of life's great puzzles, isn't it, that this whole issue of hand hygiene needs something as we have. And when I was Chief Exec of the Australian Commission on Safety and Quality in Healthcare, when I got there, one of their major programs was dealing with healthcare-associated infections, and which is a really important part of safety and quality, particularly in hospital care, and had a range of activities developing infection control guidelines, education modules, and so on. But one of the issues, and what we know, is that the one way of spreading infections is from the hands of the healthcare workers or the staff from one patient to another. And there's good evidence that that's the case. There's been good evidence, as you point out, for 150 plus years from the time of Semmelweis. And interestingly, Semmelweis had trouble convincing doctors back in his time, and he ended up in an asylum. He had a very tragic end. So it was felt, and with evidence from Victoria and from Lindsay Grayson's work at the Austin Hospital, that, and then across Victoria, that a hand hygiene initiative would make a difference. And there's, through Switzerland and Didier Patet, 5 moments where with each patient you need to consider you're going to need hand hygiene. And we put this, remember taking this to ministers, and who are as puzzled as you just expressed. Ministers find it hard to understand that you need a national initiative for something as elemental and as basic as hand hygiene. But you tell them sadly it's needed, and in fact when you look at all the groups right across from clerical staff, from orderly staff, from kitchen staff, nurses, students, doctors, the worst with hand hygiene have been doctors. And that remains the case, though they are much better than they were as a result of this hand hygiene. My observation is that the best with hand hygiene are health ministers when they go to hospitals, because they've got cameras on them and they're shown where this is where the stuff is, so they do it, then they do it again. They shake a patient's hand and they keep doing it. And it's complex. It signifies the whole issue of putting evidence into practice. And there's often not just one thing. And people, doctors and others might say, look, we're busy, we haven't soiled our hands, we just used hand hygiene with the last patient, why do it here? Where is the stuff that you want me to use? And in fact, one of the other things is people don't see that when they touch it, their hands have got maybe potentially contaminated, they touch someone else, there's nothing immediate to see. And as they rush around, they just let this slip. So it slows them down in some ways, even though this has now been made easier and easier. So it is almost a metaphor for the whole issue of putting evidence into practice, how you need to use imagination, a whole lot of techniques, because if you nail this one, then you can nail just about anything. And there's no doubt, though, that through the national initiative, which is across 700 hospitals, and it's part of what's being assessed through the National Safety and Quality Health Service standards, big changes have been made, and there is significant improvement. By the way, the best, you'll be delighted to know, are nurses. They are or have always been the best with hand hygiene, and in many ways, thank God, because they touch patients a hell of a lot more than doctors do.
Thanks, and it's a beautiful way of turning that whole question around to a huge opportunity. If you can solve this one, you can solve anything.
Yes.
Terrific.
Thanks.
Liz, Canadians are much smarter than Australians. You must be better at this than us.
Well, I mean, I would be optimistic about this one. I think it's hand hygiene as an example. It's a banner example of where change has been possible across broad cultural and social domains, which I think it's important to to realize that there may be different approaches and different contexts. And, you know, to just think, you know, track back 10 to 15 years ago when we weren't using alcohol-based hand rubs, and imagine an ICU nurse having several contacts with a patient per hour and having to spend maybe half of her clinical time washing her hands, and how difficult that was. And then think forward to the evidence base that has surrounded. Now that we know alcohol-based hand washes, they're not only easier, they're not only more accessible, but they're more efficacious, they work better. And so that same nurse does not have to spend 50% of her time washing her hands. And along with that, there's been significant initiatives, both nationally, as Chris has mentioned, and internationally. And these have really, really been robust, evidence-based initiatives that are ongoing globally in multiple countries across the developing world, and they're adaptive. So they include behavioral modification, and they're adapting to different cultures, which is actually, I think, a valuable lesson when we're thinking about any infectious diseases. You can't just bulldoze in there and sort of and put your own societal values on that culture. You have to adapt to that culture to actually affect change there. And so this, in terms of the hand hygiene story, this has included reforming Muslim countries to be able to use alcohol-based hand rubs, which was a huge barrier just by communication and education. It's included translation of valuable information into multiple languages. And so the whole education communication thing has been absolutely vital. And I would say that, you know, from the Australian example and in other countries as well, being able to move from hand washing rates of compliance rates of less than 50% now to approaching 80% or higher. So I think it's a very, very good success story.
Thanks, Liz. So we've got about 15 minutes before we go to Q&A. So what I might now do is just ask one of the panelists one question, and then just try to get through a few questions before we go to the audience. So I might start with David. David, yesterday there was a symposium at Murdoch around antimicrobial resistance, and it came under the kind of umbrella of One Health. Can you explain to a kind of non-health audience what this thing is called One Health and why they should care about it?
Yeah, well, you know, One Health is the interaction of species at the animal-human species barrier, is really what it is. And when an infection crosses from an animal into humans, it has several pathways it could take. It can just cause one infection. For example, when a dog bites a human in rabies, it's a dead end. It doesn't spread further. It can spread across that species barrier, such as does avian flu here in the Asian region, and it can infect a human, and then a few more cases occur, such as also is occurring with Ebola. It spreads into a few cases, and then it disappears. And then there's the third type of emergence, which comes at the human-animal interface from an animal to a human, and it finds human as a very acceptable host, and it remains with that human. And the best example of that is HIV, which probably emerged back in the early 20th century and now is an endemic infectious disease among everybody. So there are three pathways that these organisms can take, and that's what One Health is all about, is trying to understand, first of all, with a risk analysis or a risk assessment, what will happen when a disease emerges, and then at the same time making sure that it's not the humans that are the sentinel population and show the disease. It's trying to push back the paradigm so that we can detect these in animals first and prevent them from emerging into humans. Today, when a disease emerges, the human is the first one usually that's identified, and then you go back and find it in the animals. What we want to do is make sure that the animals and human population are being considered together so that possibly that paradigm can be shifted. So One Health is all about working together in both the animal health sector and the human health sector. And a good example of that is in the UK, where once a month the animal sector and the human sector in health get together and do a risk assessment of everything that's going on in the world that they know about. They get this from many different networks, and they say, is this a threat to either our animal or human populations in the UK or to both? If they don't know, they get more information and they make that decision. That's One Health in action.
And that's a beautiful summary of just, video. That bit of video is a pretty good 2-minute introduction for anyone. So we might sell that if David's okay. So there were a couple of themes that came out of that for me, what David said. One is the partnerships theme between animal and human kind of health sectors, and he also previously mentioned the public-private partnerships. So we might come back again to that, encourage questions from the audience about that. But the other was around risk assessment and, finding ways to actually comprehensively assess the risk between various stakeholders, independent, if you like, of the kind of community fear or related to that, but some kind of little bit more objective than that. So I might go to Liz and say, and you talked about your experience working with HIV and other infectious diseases. Is there a danger of overplaying the threat of some of these newer emerging infectious diseases without proper risk assessments? And, again, the casual observer might say, look, we've got through HIV, SARS, influenza, we'll get through Ebola. You're hyping it up a bit.
I think, again, with each outbreak, there's something to be learned. With the more chronic diseases like HIV and tuberculosis, the issues are slightly different, but there's been a very robust global response to those diseases, and I think and a very set group of targets to reach in terms of goals, and I think we can learn from the chronic diseases as well as the sort of more acute outbreaks in terms of disease response. In the case of HIV, again, that's been a success story over the last few years, where now, by 2012, I think 10 million people were actively in middle and low-income countries were actively engaged in antiretroviral therapy, which is really the main public health measure to reduce further transmission of HIV is antiretroviral therapy, and new targets now for 2015 include getting at least 15 million, and that's for the first time perhaps an achievable goal that will reduce transmission of HIV. In the case of tuberculosis, there's also been a robust global response to the point that I think since 1990 the mortality from tuberculosis has decreased by 50%. And again, when we think about these in broad terms, in terms of thinking whether about it's an acute outbreak or a more chronic disease, the situation and the response has to be somewhat the same, in that we don't actually have this pattern where we're going like this, and that's somewhat what happened with SARS. We actually have to keep up a high level of vigilance and responsiveness all the time, so never really letting it down. And with TB is also a good example where drugs have been deployed, where the laboratory has been a very important component in laboratory innovation, has been a very important component. And the same is happening with HIV, and the technologies and the lessons learned from these diseases are very helpful when new outbreaks come in terms of rapid deployment of novel laboratory technology. So they all sort of synergize with each other. I would argue that it's very much a...
Thanks, Liz. And again, you remind me of the actual strength and success of public health. And part of our, our challenge in terms of the further investment is to actually describe what an amazing investment it has been in public health and what it can actually deliver, and how cost effective that is, to justify, the further, investment. So that's really useful. Just ask David and Chris. We've talked about public-private partnerships, but some private organisations now are big international players. So most of us don't get to see the work of, the Gates Foundation or the Global Alliance for Vaccines, which is big public-private. These tend to be new players on the international scene. Have you come across them, and how do they engage, and how do we engage them in terms of international public health?
I would say that the Gates Foundation has probably made one of the greatest changes in the way global health is done of any foundation that's ever existed. It's done that, and I can give you an example of how the Gates Foundation works and how its goal is to develop new products, or products that can be better used to deal with infectious diseases. And a good example of how they work is a technology transfer that occurred for a new vaccine that was required in sub-Saharan Africa. Sub-Saharan Africa has meningitis outbreaks every year in winter. And there was a new vaccine developed for meningitis called a conjugate vaccine, but that was developed with an industrialized country market in view. It has 4 different parts, 4 different meningitis components in that vaccine, and it was designed to be used in industrialized countries, and especially for pilgrims going to the Hajj and other places where there was a need to have vaccinations. Africa was neglected because it didn't need this vaccine. It needed a single vaccine, a single conjugate vaccine, not this 4-component vaccine. So the Gates Foundation supported a transfer of technology to India to develop a meningitis conjugate vaccine for use in sub-Saharan Africa at less than 50 cents a dose. That vaccine is now 50 US cents. That vaccine is now available, it's on the market, and it's being used now in sub-Saharan Africa to deal with meningitis outbreaks, and hopefully eventually can decrease the potential for outbreaks in West Africa, which are quite devastating. So just an example of how the new partners have come in. They've developed new products which are very useful, but in some instances, and possibly unfairly, they're accused of distorting the international agenda. Of course, they have their own desires, their own needs, and their own wishes, and we have to work with them to make sure that what they invest in is what's really needed. And the Gates Foundation does that to a great extent, working with WHO and others to try to make sure that what they do is necessary.
Given the panellists, and I think there'll be a lot of people in the audience wanting to question them, I'm going to ask Dan to come up and just start question time 5 minutes early, because I'm keen to give everyone a chance to ask the panellists what's on their mind.